Hello everyone, my name is Brian Forbes and I've chosen to explore the subject of pre-hospital management of traumatic brain injury. I've been working as a paramedic for almost 6 years, and through that short time I have noticed that responses to trauma patients who have suffered some sort of head injury seem to have a higher incidence of mortality. In North America, trauma remains one of the leading causes of death in individuals aged 1 to 45. Traumatic brain injury accounts for the majority of trauma-related death and disability, and the mortality rate increases to 75% when the patient also presents with hypotension. This presents a common issue across North America, with limited currently accepted practice. Cerebral edema can cause increases in intracranial pressure when the degree of parenchymal volume exceeds compensatory responses. This can be either vasogenic, caused by the breakdown of the blood-brain barrier, cytoxic, cellular swelling of necrotic and apoptotic cells, or interstitial, from bulk flow of cerebral spinal fluid or fluid from plasma across the blood-brain barrier. Pre-hospital management of traumatic brain injury should be centered on preventing and limiting increased intracranial pressure and secondary brain injury, in addition to the expeditious transport to the most appropriate facility. Hyperosmolar fluid therapy is widely used in long-term management of the traumatic brain injury patient, and recent studies have shown that initiating hypertonic fluid administration in the pre-hospital setting has a significant outcome on patient survivability. However, there has been much debate over which fluid to use and in which concentration, and by which manner it should be administered. Presently, mannitol has been accepted by many as the standard hyperosmolar agent in the management of intracranial hypertension, but recent evidence suggests that the administration of mannitol may have several adverse effects, such as dehydration, hypotension, metabolic disorders, renal failure, and rebound intracranial hypertension. For these reasons, hypertonic saline is emerging as a safer and more effective treatment. Hypertonic saline administration increases the osmotic gradient between the blood-brain barrier, subsequently pulling fluid from the interstitial space to the intravascular space. This is particularly useful in counteracting the effects of accumulated extracellular osmoids caused during death and lysis of ischemic cells. In 2007, a study concluded that drawing fluid intravascularly from the interstitial space, hypertonic saline lowers intracranial pressure and increases blood pressure without reducing cerebral blood flow. Another recommended intervention for the treatment of intracranial hypertension is controlled hyperventilation. This subject has been widely investigated, and many researchers have questioned the safety of hyperventilation in the reduction of intracranial pressure. This is due mainly to the compensatory mechanisms triggered by increased intracranial pressure and exacerbated by hypocapnia. Hypocapnia causes cerebral vasoconstriction and therefore decreases cerebral blood volume. Consequently, decreased cerebral blood volume leads to reduced cerebral blood flow, which can cause ischemia and secondary brain injury. This mechanism occurs simultaneously with an already reduced cerebral blood volume, secondary to hypovolemia, and may be more detrimental to the patient's survival and outcome. However, multiple studies have shown that maintaining an end-tidal CO2 level of between 30 and 35 millimeters of mercury can be effective in reducing intracranial pressure while limiting the loss of cerebral blood volume. There still remains some controversy surrounding which pre-hospital treatment regime has the greatest impact on the survivability of patients with increased ICP. So my research question for this is the administration of hypertonic saline more effective than normal saline in addition to controlled hyperventilation in the treatment of traumatic brain injury presenting with hypotension? So the methodology of my study will be a multi-centered, randomized, blinded, and controlled trial. Hypothetically, with the approval from the University Health Network Research Ethics Board, this study aims to be in adherence to all compliances listed therein. The hypertonic saline and hyperventilation with normal saline study is a two-phased, blinded, controlled trial designed to evaluate clinical outcomes of trauma patients suffering from hypovolemic shock and severe traumatic brain injury. Emergency medical services from Peterborough County, Durham Region, York Region, Peel Region, and the City of Toronto will work alongside with local hospitals and regional trauma centers to execute study protocol, collect, and submit the data. The study will be executed in 2 separate phases over a 2-year period, as outlined by the following clinical criteria. So some of the inclusion criteria for the study would be age 15 years or older, or 50 kilograms if that cannot be determined, any blunt or penetrating trauma, GCS less than 8, or systolic blood pressure of less than 90 millimeters of mercury. And the exclusion criteria would be ages less than 15 years or less than 50 kilograms, known or suspected pregnancy at the time of injury, vital signs absent with ongoing CPR, severe hypothermia, or burns greater than 20% of total body surface area, or the inability to obtain intravenous access. So phase 1 of the study, first phase of the trial will evaluate the efficacy of hypertonic saline in the treatment of traumatic brain injury and hypovolemic shock. This phase will be conducted over a 1-year period in which all patients suffering from severe traumatic brain injury and hypovolemic shock will be administered an intravenous infusion of 7.5% hypertonic saline. Saline will be administered with an initial bolus of 10 milliliters per kilogram to a maximum of 2,000 milliliters, or systolic blood pressure of greater than 90 millimeters of mercury. If the hypotension resolves after the initial bolus, hypertonic saline should be infused at a rate of 10 milliliters per minute. The second phase of the trial will evaluate the use of controlled hyperventilation and normal saline over a 1-year period. Patients with signs of severe traumatic brain injury and hypotension will be hyperventilated with controlled EtCO2 range between 30 millimeters of mercury and 35 millimeters of mercury. In addition, patients will receive a fluid bolus of normal saline at a rate of 10 milliliters per kilogram to a maximum of 2,000 milliliters, or again until the systolic blood pressure is greater than 90 millimeters of mercury. In addition to the study protocol, all patients should be regularly monitored for signs of fluid overload and treated in accordance with basic life support patient care standards. So the outcome measures for this study will be measured at time of discharge, 30 days post-discharge, and 6 months post-discharge. The primary outcome measures for the study will be measuring the survival and functionality and disability of the patients. Paramedics will document all applicable information as per the Ambulance Call Report, or ACR, documentation standards. A team of individuals independent of the study committee will compile and analyze the data. The analysis committee will gather the following information from the ACR: all non-identifying demographical information, primary problem and chief complaint of the patient, and the amount of fluid that was infused, and any vital signs pertinent to the patient. Investigators will collect the following information from a patient's medical records. From local hospitals and regional trauma centers. Again, vital signs, and including heart rate, respiratory rate, pupillary response, and blood pressure, in addition to neurological responsiveness and increased ICP. A follow-up interview will be conducted by investigators 6 months following the date of incident via telephone. This interview will primarily determine neurological outcome of the patient and any further complications that may have resulted. In terms of data analysis for the study, the collected data will be blinded and randomized by a computer-generated unique ID number. This will allow researchers to analyze the collected data with minimal bias. Statistical regression analysis will then be performed to determine relationship between the dependent variable, patient survivability in this case, and the independent variables. Again, the administration of 7.5% hypertonic saline and administration of normal saline and controlled hyperventilation. Hypothesis testing will be conducted, accepting a 95% confidence interval as statistically significant. The primary endpoint of this study is to determine which treatment regime has a greater positive effect on the mortality and morbidity of patients suffering from traumatic brain injury and hypotension. Thanks for listening, guys.